Welcome back, everybody. You're listening to Cut the Shit, a podcast series that aims to take a closer look at the impact of the IT industry, both the good and the bad. Cut the Shit is brought to you by Plow Networks, a managed IT services company based just outside Nashville, Tennessee. I'm Brian Link, EVP of Products and Services here at Plow, and I'll be your host for this series. I'll ask questions, and with the help of our guests, try to dig deep on some of the key challenges we all face dealing with IT. So with that, let's cut the shit and get started. On today's episode, I'm really excited to have healthcare technology executive Hal Andrews as our guest. After working as an M&A attorney in the early 90s, Hal became active in the Nashville early-stage healthcare scene in the mid-90s and never stopped. After successful stints at a number of healthcare services startups into the mid-2000s, Hal moved into the data analytics space in the late 2000s, where he continues to focus his efforts. Since 2017, Hal has served as CEO of Trilliant, a data engineering and predictive analytics company focused on helping healthcare providers leverage evidence-based insights so they can do a better job of investing in the right growth initiatives. During our conversation, we dive into the impact the internet and distributed computing has had and continues to have on healthcare delivery, the way providers are adjusting to the increasing consumerization of healthcare, and why he is cautiously optimistic about the ability of predictive analytics to make healthcare better. Now, I would be remiss if I didn't mention that in addition to his day job, Hal also happens to be one of my closest friends, and I am both grateful for his friendship and his willingness to share his insights with us today. I hope you enjoy my conversation with Hal Andrews. Hey, Hal, it's good to see you again. Hey, before we get into the meat of the discussion, how about we start with you giving us, an example of the most interesting use of technology or a hack in healthcare that you've seen or heard about from clients or colleagues, or even in your own personal experience over the last few years. There's been a lot of crazy things that have happened, so figure you might have had a first row seat to something that was surprising or interesting.
Well, I think the biggest thing has just been distributed computing, which I guess, started more than a few years ago, but I think my crew tells me that it was really the Netflix prize in 2006 that got people going on the power of distributed computing. And I think that in a nutshell is everything. I think there's a lot of talk about big data out there and about machine learning and artificial intelligence. And my guys assure me that the data science is actually the easy part and the data engineering is the hard part.
Yeah.
And I think, the thing certainly for this century is being able to do distributed computing at scale. So maybe the biggest innovation is what Databricks has done and Spark, and allowing you to process massive amounts of data at speed.
That's fair. So, to get us started, I always like to kind of start with some sort of a warm up. Usually, back in the days when no one was traveling, I was like, so where are you? Have you gone anywhere? I don't need to ask those dumb questions anymore because even Joe Biden said that the pandemic is over, even though I know there's a lot of people walking that back. Obviously COVID is still around, but we sort of lost what the definition of pandemic means, not to get weird about it, but to help us kind of get started, and for the audience's sake, Hal and I are friends. We've known each other for a good while, so I already know your resume. But if you could just give us kind of a thumbnail sketch on your background and sort of, again, as we've joked before, we've both had a lot of jobs, so you don't have to go line by line on the resume, but kind of walk us up to and maybe emphasize a little bit of where you are today.
Well, I'll give you two versions. One is my wife's version. We will be married 25 years in November, and she said that I've had 13 jobs. And I've asked her if she went to yoga and played tennis today, and she said yes. I said, okay, don't worry about it. I started as a lawyer. So I started as a lawyer in the early 90s in Nashville. I thought that I was going to be a music business attorney because I had grown up in the music business. And the law firm that I got to represented HCA and Surgical Care Affiliates and FICOR. And they said, that's great, you can do that at night. But during the day, you're going to do mergers and acquisitions for healthcare companies.
Stuff that people pay us to do.
That's right. And that's what we're going to pay you to do.
Right.
And so I said, great. And so for 3 years, I chased the music business at night and did hospital M&A during the day. And in 95, I picked a guy who nobody's ever heard of named Daryl Dodd. And I laughed at this guy whose mixtape I heard for a song called Indian Outlaw and said, Tim McGraw is never going to make it just because he's the son of a Major League Baseball player, which is how I got in the healthcare business. So I worked in healthcare services startups from 96 to 2007. And then in 2007, took over a small data analytics company, and we turned it around. And that's where we started building the crew that is still around today. So this is our fifth time in healthcare analytics or technology. And at this point, the crew's about 25 people who've been along for at least two of the journeys. A couple of people have been along for as many as four. So 2007 to today, it's really been clinical data and strategy data for healthcare.
And that's, again, as I was preparing for this conversation and thinking about it again, you and I have known each other for a good while, and I had a pretty good sense of your career, but I hadn't really thought about it in maybe meta terms or not that there's a thematic, not that our careers necessarily have a theme. I mean, I know mine doesn't. I've been trying to figure out, if you were to ask my wife, you'd get probably the same sorts of answers. I don't know what the hell he does. He seems to be figuring something out. So and I guess that's really all you can ask for. But I was thinking about your career path, and again, as someone who's been in technology in a totally different way for a long time, it seems to me that when I think about your career, there's sort of three parts, right? There's the law part, which was more the entree, that was an early part. Then healthcare services, then really data analytics in the healthcare, applied data analytics in the healthcare space. It feels like that arc sort of, not the law part, maybe that, because if you're going to work in a regulated industry, it helps to understand the law because, regulation is written by lawyers. So yes, from that standpoint,
and 22-year-olds who just graduated from college.
Well, right. Both are dangerous in their own ways. So, but it seems your career path has tracked what I'd call the opportunity space created by connectivity and data processing, those two revolutions that have happened really over the past 20 or 30 years. Even goes back really into the late 70s, early 80s, but certainly in the 90s forward. So let's call that the internet plus mobility plus cloud sort of revolution that we've seen. I mean, is that a fair characterization when you think about your career arc?
I think it is, and it's not a way that I have ever thought about it in terms of what I was doing. Back to your comment about, what are you doing in your career? For me, it's always been to follow the muse, and sometimes the muse takes you to places where things aren't really proven out or fully developed. And so if we go back all the way to 96, the first services company I went to was developing ambulatory surgery centers in very rural parts of the U.S., places that people have never been or heard of, like Wartburg, Tennessee, and Defuniak Springs, Florida. Now, some of them we got right. When we got to Cedar Park, Texas in 97, there was one doctor in Cedar Park, Texas, and now there are two hospitals as Austin has just grown over the top of it.
Right. Yeah.
But in trying to deliver care to rural areas, we were relying on technology to do that because you couldn't meet the staffing requirements for specialists. Right. So, for instance, you couldn't get a radiologist to go to Wartburg, Tennessee, and so you had to figure out how to get a scan back to Nashville for a board-certified radiologist to read it. And I mean, in the early days, we were moving CTs and MRs over phone lines, and sometimes it made it all the way through, and sometimes it didn't.
Yeah.
And dial-up internet was hard enough, but dial-up MRI scan is super hard.
Yeah, and that's interesting because, I was thinking about that. I mean, again, my career and yours are totally different, but there are parallels in the early days of what we were trying to do, financial planning on the internet, and just trying to figure out how to gather information and get it, from the person to the system to be able to analyze it, was along the lines of what you just said, which was broad. This is early 2000s, so we're already pretty significantly, quite a bit of progress in terms of I'll call it broadband. It wasn't broadband yet, but in terms of capacity, right, bandwidth, availability for folks, and even then, it was, I mean, it was a nightmare, like to be able for things to actually successfully, complete. And that's something. I mean, literally, the young folks who work for you and me can't even understand that. Like that's hard for them to even imagine. Like you say things about waiting for a web page to load, and they don't know what you're talking about. They just assume it was broken. It's like, no, that's actually how it worked. And so, that watching that change. So you've had sort of this really interesting perspective when you think about these core technologies. What are, if you can kind of take that late 90s to early, we'll call it 2010, kind of that range. That's a big change in what was what core technologies could do for a healthcare company, for anybody, really, a media company, a manufacturing company. It didn't really make any difference, right? These were fundamental technologies that could be applied in a bunch of different ways. What are some of the impacts? Can you think of, I mean, I know you can think of a lot, but can you give me a couple of examples, maybe both good and bad, of some of the impacts you witnessed on the healthcare industry from these changes, really in connectivity and data, the ability to process data in a distributed fashion, because there were already big mainframes. People could process data, but it had to be on site right there. So really distributed data capability and connectivity, and maybe some impacts from that you were seeing.
Yeah, I think the interesting thing about technology in healthcare is that you can often see it at the individual patient level. And so, back in the 90s, from sort of 96 to 2000, at the company that was doing the surgery centers, and then following that with the company that was actually doing the radiology, we were enabled to do clinical reads of severe illness for people who were in very remote areas in the middle of the night. And it seems like a small thing, but if you're I remember a case where a patient was in Gadsden, Florida, which is sort of in no man's land between Pensacola and Tallahassee. They were in a car wreck, and they needed a radiologist in the middle of the night. And through technology, we were able to get a Vanderbilt certified radiologist to look at the scan and give the caregivers on the ground in Gadsden instructions about how to treat the patient at 3 a.m. And, even 5 years prior, you couldn't get the scan moved from one place to another. And so everything, we started on phone lines. I remember one day we found out that a company called MCI was going to deploy what was called a frame relay, and that was going to be a big jump forward. And now, everybody has a computer in their pocket. But in '99, that was a big jump. And I think when you think about the power of distributed computing, we worked on a project at another company for HCA where we would read, using NLP, we'd read the pathology reports and the radiology reports as soon as they landed at HCA to look for the evidence of cancer. And there's a case that I know HCA told the U.S. Senate about a young female, I think she was 26 or 27, who'd been in a car wreck. She'd come into the emergency department to rule out broken rib cage, and in the radiology report, the radiologist noted in what's called a secondary finding, a mass on the lung. And before she even got out of the emergency department, they had her come back in. They did a scan of her lungs and determined that she had cancer, and they were able to start treating her 2 days later. So, absent sort of the fluky nature of a radiology scan for a car accident, and technology, she might have gone weeks or months, or maybe even years without being diagnosed. So, I'm skeptical that technology can solve all the problems in healthcare, but there are some really great examples of how it can change an individual's life in a really positive way.
Well, it's interesting because we've talked specifically about technologies related to how it might change on the provider side, but obviously the same technologies have impacted consumers in a huge way in terms of the way they interact with everything around them, whether that's from media to healthcare to banking to et cetera. And so I would assume, I know I've been doing some reading about Trilliant. You guys are the consumer focused nature of healthcare, at least the implications or the burgeoning impact of consumer driven preferences and choices, and how that plays a big role in healthcare, is something I understand that you guys spend some time thinking about. So I'm just interested to hear. I'm guessing that consumer behavior has changed dramatically as a consequence of technology. How do you guys see that playing out? And where do you see where are providers maybe doing a good job of dealing with it, or using it as an advantage as opposed to it being seen as a problem? Because that's oftentimes the perspective on consumers. Oh, these consumers think they know everything now. They got all this information. There's a lot of that. There's a lot of power in owning or controlling information. And in this case, it's, there's very little control of information anymore in any business. And I'm guessing healthcare is no different. So I've talked too much. Hopefully that made some sense. So
I think that also goes back to the mid 90s too. I think the internet browser is the thing that in hindsight has really caused the change in the consumer behavior. And it is the access to information. I think before the internet was accessible by the public, people were conditioned to do whatever their doctors told them to do. And what their doctors told them to do was limited to what their doctor knew. And I think about my father and my grandfather, who were physicians, who were good physicians, and they were conscientious physicians, but there was only so much information that was available to them the entire time they practiced. And with the internet, you have access to information for providers, you have it for patients, you have it for payers, you have it for life science. And I think certainly just the availability of information changes behavior. The second parallel I would say is what healthcare is experiencing now is the fact that they are lagging behind what other consumer focused industries do in terms of data. And so Amazon's an example, Netflix is an example, Walmart's an example.
True direct to consumer providers.
Right. People who really have a relationship with consumers understand those consumers in a way that healthcare has never had to. And it certainly fits and starts for healthcare. There are different parts of the healthcare industry that do a better job with that than others. Probably pharma is the most obvious in terms of targeting commercials. I've noticed that my Sunday afternoons are filled with fewer commercials for beer and more commercials for drugs. And so they've clearly dialed in my age on my cable provider. But I think there's more information about choice in providers. There's more information about cost. And as other industries have exploited their knowledge of consumer psychology, that's starting to seep in to healthcare as well. And so the way we think about it is that there are certain people who are clinically identical, but whose psychology or their psychographic profile is wildly different. There are other people who are psychologically identical and clinically different. And I think we're really just at the beginning from the healthcare perspective of A, understanding that, and then B, targeting messages to consumers based upon that information. And so Amazon's been doing it a long time. The Democratic National Committee and the Republican National Committee have been doing it for years.
Sure.
And so there's some basic things that Procter and Gamble does that are new to healthcare. So we're just beginning to scratch the surface of those things.
And are there particular subsets of healthcare that are more amenable to this approach, or is it an aha moment really across the board? I mean, you've got third-party payer issues in the sense that, it's not your healthcare provider they have a direct relationship with you as a consumer, but you don't pay them if you're insured, right? Or you pay a part of it, but and that's a strange relationship as compared to, say, an Amazon or a Netflix or a Walmart, right? Walmart, if you're going to shop at Walmart, you either go into the store, you go to walmart.com, and you're the only show in town. You give them cash or a card, and that's it. And as everyone who's had health insurance knows, healthcare is not that simple. So I'm just curious, are there segments or areas where you're seeing more interest in this than less? I'm just curious about the perspective on that. And if so, why?
Well, the immediate focus on the provider side is that the patients haven't returned to historical volumes pre-pandemic. And there is a big focus on the provider side of where did the patients go? Why haven't they come back?
Where are they? Right.
And are they coming back? And I think the sort of aha moment that we see for healthcare providers is analogous to grocery stores, as much as the health systems wouldn't like it to be. There are certain things that, I'm happy to buy at Kroger, and there are other things that I probably want to go to Publix for. And then there are a few things where I'm just going to go suffer through the line to get to Whole Foods. And healthcare consumers are a lot like that. There are things they will do that are the very basics, like urgent care, where they are susceptible to things like convenience and hours and proximity. There are certain things that are very complicated where they want to go to MD Anderson or Memorial Sloan Kettering. And so it's really it's really similar to the behaviors you see in other retail focused areas, but health systems are only now beginning to awaken to that.
It's interesting because when you say those things out loud, it seems obvious because all you have to do, or at least all I do, is reflect on my own behavior, right, and think about myself as a healthcare consumer. And I'm not sure that my providers are aware of that in the context of me, right? So, and certainly they have never approached it in that way. I live in a city with a large academic research hospital, Wake Forest, and a large outpatient, set of providers attached to it. And so that has that has mind space here. But to your point, I would probably a generation ago, they probably literally sucked all the air out of the room in this market. And that's just not the case anymore, right? Everything from urgent care to online providers to, there's just the stuff that's happening now. It's much more diverse in terms of the options from a consumer perspective.
Well, and that's actually a good example of how technology can maybe lead you a little far down the path and get you stuck. As you know, I've had many surgeries to replace my aching joints. My internist was at Vanderbilt. I had 2 hip replacements at HCA and 2 shoulder replacements at St. Thomas. And I did all the joint replacements in between primary care visits. And so when I went to see my internist at Vanderbilt, he said, "Have there been any changes to your health since the last time you were here?" And I said, "Well, there are 4 joint replacements." And he immediately turned to his EMR and started typing in. And I had sort of a It's a Wonderful Life moment and told him, no, Zuzu's pedals aren't there, right? I didn't have these surgeries here.
Right.
And so
yeah. There's no record of that here.
yeah, like everything, technology can become a crutch. And he thought because they had the leading EMR system that it had everything he needed,
Yeah.
When in fact it didn't have a couple of key data points.
Yeah. It's only as good as the information put into it, right? And to your point, your pointed comment earlier about data and data engineering being the problem, not machine learning or NLP or AI. Not that those things are not miraculous and improving, but it doesn't matter if you don't have good data.
Right.
You can release the greatest AI algorithm in the world on a shitty data set, and you're not going to get much out of it, right? I mean,
that's right. The models can go horribly wrong.
That's right. All right, so let's talk specifically about Trilliant, since this is where you are now, and I know it's been an exciting ride. Again, you and I have talked about it, but having been a kind of person who's worked most of his career in jobs that no one could explain to other people what it was that I did, particularly, it was always hilarious when I heard my friends, my children's friends, ask them, hey, what's your dad do? They never had any. I mean, even as they got older, the closest they maybe ever came was, he does something in banking. And I never worked for a bank in my life. So, that was the closest, and that was the closest they ever got. At one point, they said I made T-shirts because our company had T-shirts with our company's name on it. So, that's like straight out of Silicon Valley.
Very
right?
tangible.
Yeah, exactly. They could get that. They couldn't really get anything else. But if I had to describe it to someone, I'd say it's a predictive analytics company that happens to be in the healthcare space. Is that a fair characterization?
Yeah, I think It is. And, we've spent the last 5 years getting really good at the market analytics. And to your point, getting really good at the data that's in the database. The team we have has produced amazing models in different industries, but healthcare data is really messy. And A, to get it where it's normalized, and then B, to be able to process it at scale, has taken 3 really hard years of work to be able to do that, where the models can be informative. And so we focused on getting the foundation right, so that we could start doing the predictions. Healthcare is a $4 trillion industry. It's the largest economic engine in the world, except for the Chinese and Japanese economies. So the U.S. healthcare industry is bigger than the entire GDP of Germany, for example. And we've really focused on predictions because between the regulatory environment and the cost environment, the capital allocation is a really important component to get right. The decisions that people are making are $50 million and $500 million and $2 billion decisions. And we're focused on predictions that allow people to make the best capital allocation decisions they can.
And are those capex decisions around facilities, so kind of PP&E kinds of decisions, investments in software? What are the nature of those? This is a question more about healthcare than it's about Trilliant, and so I'm showing my ignorance. But just curious, what are those capex? What does that look like in kind of in a range? I mean, obviously it's all over the place, but in sort of a general range.
No, that's right. A lot of it is around new facilities. A lot of it is around M&A, getting into new markets. A lot of it, though, is around the basics of blocking and tackling. If you're a large pharma company or a large medical device company, you want your sales reps in the markets where the clinical pathology will arise. And we see time and time again where people have if you think about their assets, whether they're salespeople or physician liaisons or whatever it is, they have their assets misallocated to where the market is. So our real focus is, where's the growth by service line? What is it that you're trying to sell or deliver? And are you investing in the right markets with the right resources?
And so, in that context, as I think about Trilliant, I had a question that it's maybe kind of a dumb question now that we've had this conversation or gotten to this point. But does mobility, or the idea of mobile computing or mobile access to data, is that an important part of the value prop at this point, or is this more at the business decision level? So it's nice, but it's not critical yet, and maybe there's something downstream around that aspect.
No, mobile is definitely important. I mean, if you think about the healthcare industry, nothing really happens in the US healthcare industry that doesn't involve a provider. So a provider, usually a doctor, makes a recommendation or writes a prescription or writes an order or makes a referral. And and so if you're going to influence those decisions, you have to be on the ground talking to the physicians. And we have in our database 2.6 million providers. And our theory is everybody cares about at least one of those providers. And in fact, most people care about thousands of them. And so being able to be face to face with a provider with relevant information to try to influence the conversation is critically important.
Gotcha. Okay. Obviously, security and healthcare go hand in hand, right? I mean, protection of information is not just it's not just an ethical proposition; it's a legal one, right? PHI is obviously heavily regulated in terms of how information, and particularly critical or private information, is handled. How do you guys think about? I mean, this is obviously, you've been doing this your whole career, so it's the water you swim in. But as looking at it, as we've moved into this more distributed computing, large data sets, I'm assuming you've got a bunch of unstructured data. You're hoovering up data from lots of different places and then trying to put some structure around that to be able to run models against. How has the security aspect, how do you think about that as the CEO? How much of your time do you spend thinking about that aspect?
Well, less than I used to, and I think that's another big development in technology is I'm going to put it under the heading of cryptography. But in the past, I'd say past 8 years, hashing the data has become the way that almost everybody works with the data. So a company called Datavant, which is based in San Francisco, started by a guy named Travis May, who started a company called LiveRamp that he sold to Axiom. And Travis bought a little company that was hashing the data so that it's de-identified, and then creating a network of people around that data. At this point, we've moved. When I started here, we probably handled probably 95% of the data was identified. And so therefore we were worried about PHI and
Right.
all the security. At this point, it's the reverse. Probably 95% of the data that's in-house is de-identified. It's hashed and tokenized. And, we're the way we're doing it, there are actually 2 or 3 steps in the tokenization process. There's one tokenization process, and then there's some manipulation, and then there's another tokenization process. And so, you know, it would be extraordinarily difficult for someone to even crack the hash. And if they did, there wouldn't be any context for it. So we spend a lot less time worried about that than we used to. But again, that's because of, great advances in computing power over the past 15, 20 years.
Right. I mean, that's, the beauty of cranking on problems over time can yield great results, right? And the management of data and the security of the data is something that we've seen real advances in, and that's been beneficial to everybody, particularly in space like healthcare, where the stakes are really high. The flip side of that is the internet itself is an open protocol, right, by design. So it's not meant to be secure. It doesn't mean you can't drop security on top of it, around it. You can do things to make connectivity less open, but you can't make it closed in that sense. And so, in terms of access to your data and managing the sort of the ecosystem itself, have you guys been struggling with or thinking about or been challenged with things like looking at zero trust protocols or things like that to make sure, you want, obviously, ransomware attacks are terrible for everyone, but particularly in a space like yours, right, where if there's data exfiltration or limited access to information because of a penetration or a breach, that's a real problem. Just curious to know how you think about that as the CEO.
Well, what I look at internally is the constant friction between the cybersecurity team, who has promoted a zero trust philosophy, and the engineers who are trying to stretch the math as much as they can. And there's a constant tension between
Sure.
this open source thing or that open source thing, or this approach to processing data, or developing new algorithms, versus the cyber team that's saying, okay, but we have to limit access to this, and we haven't vetted that one. And I don't know enough about the details to really be the judge between them. Where I get concerned is if it looks like there's not a healthy tension. And so my focus is really on, what do I see between the teams? And you don't want them to become enemies, but you do need them to be sort of pushing each other. And then the second thing is relying on the external protocols. So we're now going down the path of NIST. We've done SOC 2, now we're going down NIST. That's a big step up.
Yeah.
And it's really just trying to allocate resources appropriately to what we should do versus what the real risks are. And again, because of the abundance of hashing and tokenization that goes on in our workflow, we think that we're at lower risk of those sorts of things than some other industries, like banking.
Right. I mean, are you guys dealing with PCI compliance, or y'all don't have to deal with that, I'm guessing, because you don't do payments, right?
One of the things about having a lot of jobs is that along the way you learn things that you don't want to do again. And
That's one of them. Yeah, for sure. Yeah. Me and you both.
We did that 10 years ago and said, nope, we're not doing that one this time.
Yeah, me and you both. I've been there and got the T-shirt and don't want another one. I understand why the restrictions and the hoops are there, but the credit card space and the payment space is.
Yep. Life's too short for this kid.
Yeah, me and you both. All right. Well, I mean, to wrap it up or kind of bring us home. You can't really talk about healthcare without talking about the government. I mean, despite the maybe the misperception that most Americans have, or at least some Americans, that we have this amazing free market healthcare system. It's about half and half, right? It's about half government, half private. If you look at the spend. So I'd say we're 50-50, right? And that government 50 is a heavy in the mix. And as you know, again, you've been working in the space a long time, so you've watched the government, and in this case, the government. I mean, we could talk about the regulars, but I'm talking probably more about the government providers, right? The Medicare and the Medicaid side of the house, the funding side of it. The conventional wisdom is that the government is behind from a technology perspective relative to the private sector. And, I'm inclined to think that on average, that's true. I don't know that that's true universally. In fact, I'm sure it's not true universally. I'm sure there are examples where that's not the case. But when you look at what you see from, as you think about the government and their sort of technology posture as it relates to being able to facilitate what they do, where do you see them doing a good job, and where are these same forces sort of at work in a way that's helping them and hurting them in the sense of them being able to take advantage of it?
Well, I think the first thing is I think about CMS as in really two roles. One is as a funder of healthcare, and two, as a processor of claims. And CMS is really good at processing claims. If you have your Medicare number and you submit your bill when you're supposed to, it is very predictable that Medicare will reimburse you. And Medicare often reimburses faster than the commercial plans like United. And so I think at that they do really well.
And my assumption is that has maybe not always been the case, or that they've invested heavily in technology to facilitate that.
They have, and in standardization. And so, they do that through third parties, sometimes through fiscal intermediaries. But, the one thing the US government can do is enforce a structure on anything. And they've enforced a structure on payment. And if you go back to the source of our material, it is claims data. And as part of, I think it was part of what brought HIPAA along in 96. In 96, it wasn't so much about privacy and security as it was about an electronic transaction set. And so there are two large transaction sets in healthcare. The clinical side is HL7, and the payment side is X12. And X12 is a framework for specific messages that go back and forth between providers and payers. And the government's done a good job of enforcing that framework. And they don't really have an incentive to sit on the money, so they don't.
Right. No float. There's no real float benefit from them. The insurance companies do understand that.
Correct. And yes, they do. I think the challenge for America, and it's not as much CMS as it is sort of where America is in terms of its thinking about this as compared to Britain. So, and maybe some of your audience does, that the National Health Service is a treasured institution in England. And part of that is because they spent the 20s and the 30s and the early 40s thinking about what they wanted. And the National Health Service was the output of literally decades of conversations about what it meant to be British. And healthcare was important, and it was established as basically a universal right. And because they decided it was important, they then set up the funding mechanisms. Now, the execution of some of the policy is not as efficient as we would think in America, and that manifests in long waiting times and understaffing and that sort of thing. But from a payment perspective, the NHS is very thoughtful. I think the key difference in America is we've never had that conversation. There are a lot of things that come out of Washington about what people want, but there's never been a national conversation for 2 hours, much less 20 years, about what we as Americans think. And I think it's that where the government, you know, it's not that the government falls short, it's that the government can't really be effective because we don't really all agree on what we're doing. And the reality is that each of us as individuals is basically potential market share for all of the actors in the system. And it just, as we age, who's interested in us from a market share perspective changes over time. Um, I think there's a lot of positive energy around how we could be more of a health system instead of a healthcare system, but absent the, you know, not even 100% agreement, but a consensus with America as a country, I don't know how we ever get there. And the last piece of that is that manifests in that lack of coordination is what's really impacting state budgets. And so I believe now in every state, the state, the proportion of state budget allocated to Medicaid is at least 20%. I know there are a couple of states where it's over 40%. And the real challenge for us is that spending on Medicaid is crowding out all of the other things at the state level, whether that's schools or roads or anything else.
And you've got the other thing is I think a lot of people tend to think that state governments are the federal government on a small scale, and they are not. It's true they can float bonds, but lots of states have balanced budget amendments. There are restrictions. There are much tighter restrictions in place at the state level than there are at the federal level in terms of dealing with, I'll call them entitlement programs, but government spending programs where costs, healthcare costs have been twice the rate of inflation, or maybe not as much as education expenses, but close to it, right?
The two biggest, they're in lockstep.
The two fastest growing components of spend in the economy, and certainly from a government perspective. So, those are, you're right. You're dealing with some immovable objects there that are problematic and lead to crowding out. No question about it. Which leads to a lot of frustration at the individual, citizen level, and yet these forces are still there, right? And they're very difficult to deal with. We didn't talk any about it, and so I won't. You and I this would be something for us to talk about next time we're together. But because you mentioned it, I was reading something on your blog, I think, talking about obviously the provision of healthcare through the workplace, as opposed to as individuals, the way you might buy car insurance or homeowners insurance is a very interesting, strange political fact of American life that happened, sort of as an accident, and yet here we are. That, to your point around something that was never meant to be what it is, that has taken on a life of its own, and has all kinds of incredible distortionary effects. At one point, if I remember correctly, you were involved in something having to do with employers and healthcare. Is that correct? Was one of your companies involved with employers?
Well, the founding company of Trilliant was focused on reaching out to employers and trying to create a connectivity between the employers and the hospitals.
Was that looking at like self-insured employers, or was it more just a way of trying to manage premium growth?
Both, and really trying to get to the health, trying to do the preventative health care to keep people from becoming so sick that they were, it was a long recovery, and it was also much more costly than it would have been if they just had preventative care.
Right. Yeah, that's another one that's, it's definitely a tangled web we've woven to get to here. And it's interesting, the NHS is instructive in that sense, but it was probably a political moment in time too that hard to capture or replicate in other contexts, for sure.
Well, it's interesting that the NHS approach came right out of World War II, and I think what you're referencing is the employer-sponsored tax deduction, which came out of
with wage freezes, right? It was they allowed you to do fringe benefits on a tax-free basis.
Right. It's funny to think that both countries did something after World War II, one of which was very intentional that persists today, one of which was completely unintentional and is the thing that confounds the healthcare system the most.
Correct. Yes. Leads to a lot of this sort of, I mean, anyway, like I said, we could go down that rabbit hole. It would be fun, but it's not for this podcast. All right. Final question. Obviously, Trilliant's in a good place. You guys have had good success and are continuing to grow, but still early stage or maybe medium stage at this point. When you think about the current state of data analytics in healthcare, how optimistic are you about its broader impact, kind of medium to long term, not just in the case of Trilliant, but more broadly, right? I mean, where do you see that? Are you seeing indications that that we're seeing a groundswell, whereas in 10 years we're going to look back and be amazed at what we've seen in terms of its impact?
I'm optimistic about what can happen. I'm not sure that we're focused on the right things from a policy perspective. So there's a huge push for interoperability. When you peel that back, what it really means is having health system A share their EMR records with health system B. The challenge with that is 50% of the revenue does not happen in a hospital, and actually 88% of the touches don't happen in a hospital. And so I don't know that interoperability is going to get us home, but I think the distributed computing and processing information at scale and starting to use algorithms to help people forecast. One of the things about healthcare is budgeting and strategic planning is a once-a-year exercise. And what I tell our board is, the second I gave you the budget, it was wrong. I just don't know where.
Right.
Healthcare does not do dynamic modeling of changes in the data. I think that with distributed computing, you can start to see people make plans before the beginning of their fiscal year, but then modify them on the fly based upon changes in the underlying data. That obviously would have been a tremendous help in the disruption of the pandemic. We're not quite there yet from a technology perspective, but I think those sorts of things in terms of, again, things the rest of the economy does. What does your future demand do to affect your supply chain or your staffing or those sorts of things? We don't do that in healthcare, but I think we can in the next 5 to 10 years.
That makes sense. All right. Well, I always like to wrap up with something. I call it personal. It's not personal questions, but it's not specific.
You know all.
Yeah, I don't have any personal questions. You already know already know the answers. So, but tell us something that you've watched or read lately that you think's worth sharing for others to consider.
Well, I'm in the middle of Walter Isaacson's biography of Benjamin Franklin, and I had not realized quite how tortured he was between his loyalty to the crown and his loyalty to America. And it's interesting watching a real statesman wrestle with those sorts of things as I think about the state of the world right now and how many difficult problems we have. I think we might all benefit from wrestling with those things like Ben Franklin did instead of just declaring. So I'm going to keep reading that and see what else I can learn from it.
Well, I've never read anything of his that isn't fantastic. He may be the best. I mean, we got 2 or 3 really good biographers alive right now, but he's certainly he's in the pantheon. I think that's clear. All right, last question. You're old, and so am I. So I'm going to ask you to go back in time a little. Tell us about your first technology memory as a child. It can't be TV or the phone.
My first technology memory is, you remember was it the Mattel or the football game with the 2 buttons?
Yeah, Mattel and then Coleco. Yep. Or maybe it was Mattel that was Coleco that I think Mattel re-released because they were the bigger company maybe.
The little flashing lights going up and down the field.
Yes.
That's it.
It was so awesome. And you could take it with you. It was it was a game changer. Like it really was.
Handheld computer. Yes. And it was 6 lights. Yep.
And it seemed like magic.
Yes.
It seemed like magic, right? It's unbelievable. Yeah. No, my son, who is the same age as your son, has seen videos of that. Like, and he kind of gets it, but not really. Like he just can't. You can't undo what you've always known. You know what I mean? Like it's one of those things. So yeah, that's a good memory for me too, for sure. Well, Hal, it's always good to talk to you. I'll see you soon, I'm sure. And thanks for coming on Cut the Shit.
Thank you.
We hope you enjoyed this episode. If you are enjoying the podcast, we'd appreciate it if you would become a subscriber wherever you get your podcasts. And if you could rate and review the show on Apple Podcasts and Spotify, that would really help us out. Or you can just go old school and tell your friends, your family, your colleagues, and hell, anybody else who you think might want to hear something like this to listen in. If you're on social media, make sure to follow us on Twitter. Our handle is @cuttheshit_pod. We are also on TikTok @cuttheshitpod, all one word, where we post lots of clips from the podcast. And last but not least, you can also watch the YouTube version of the show on our YouTube channel @Plow Networks. Until next time, take care and have a great day.